So this panel discussion is really about discussing the case study of endovascular clot retrieval. And it's really from the perspective of a stroke survivor, but bringing into that discussion all the clinicians who work with that stroke survivor on their journey along the way. Its session will be facilitated by Mark Longworth AM, and anybody who's been around stroke for a long while will know Mark. He was the ACI Stroke Network Manager from 2002 to 2016. So joining Mark on this panel this afternoon will be Lynette Hegney, and she is the Acting Nurse Educator in the New South Wales Ambulance Aeromedical Control Centre. We also have joining us remotely Fiona Ryan, the Stroke Care Coordinator for the Orange and Bathurst Health Area. We also are privileged to have Dr. Najwa Khalil, the neurointerventionist from Royal Prince Alfred Hospital, Sydney, Kylie Tatsula, who is a neurosciences nurse practitioner from Royal Prince Alfred Hospital, Sydney, and also joining with us remotely is Peter Kennedy, a stroke survivor, who basically the process will be about. It won't be his particular story, but it'll basically bring in his experience of how that process was for him. So please join me in welcoming our panellists to the stage this afternoon, who will discuss endovascular clot retrieval.
I was going to introduce all the members of the panel, but there's no need to because Michelle's stolen our thunder as always. But we do have a wealth of experience across the medical, nursing, paramedical and patient experience. I do particularly want to welcome Peter Kennedy for joining us on your experience. And I've spoken to Fiona earlier in the week, and I said what we try and do with this is to bring it down to the level where we all understand what the patient's experience really is. So Peter, you're a well-looking man, very attractive man out there in orange. I just wonder whether you'd like to start with what you were like before your stroke, and then what happened to your best of memory before you got to hospital. And we do know for one important point that Peter's daughter drove him to hospital, so that made the ambulance redundant.
Yes, after my stroke, I was getting active to walk quite a bit, exercise today. Since then, I haven't been able to do that. But the day I had my stroke, I really wasn't aware that I had a stroke until my wife, I tried to talk to my wife, I couldn't. And she said, "You've had a stroke, you're going to get to hospital." And luckily, just then my daughter arrived and she drove me to the hospital in Orange, where they didn't make it out of me. They got me going and put him in Sydney and had the procedure there, and I've been going to do that ever since.
Sorry, we just had Kylie asking a question. She can't... Kylie actually looked after you in RPAH. I just wanted to make sure that it was the same Peter Kennedy, so we're up to speed again. So it was opportune that your daughter actually arrived at your house when you couldn't speak to your wife. But why at that point do you think that the ambulance wasn't called? Why was there no 000 call?
Well, I didn't sort of think I was mobile, I didn't too bad. I know my face dropped and I was wriggling quite a bit, but I didn't think I needed that.
Okay, that's fair enough. Now, Lynette Hegney, I know you work with the paramedic aeromedical area. What are your thoughts about that in relation to the community, whether it's in the rural community or it's in a metropolitan community, about the ambulance, given that the ambulance controls take 1.2 million calls per year? So do we need better education?
If you need an ambulance, you call an ambulance. This is a common theme with I guess it's a generation. You don't want to bother people. You think you're all right. If you need an ambulance, you call an ambulance. If you have anything out of the usual, any drooping, any chest pains, anything, you use the ambulance service. If you've got a sore toe, get your daughter to drive you. Does that answer the question?
I think that answers the question quite well. So, Fiona Ryan, you're the stroke coordinator out there at Orange and intimate to the practices of both Bathurst and Orange-based hospitals out there. So what would have happened to Peter when he actually was in the car park and then walked into your hospital? Or, Peter, did you go to the emergency department?
I went to the emergency department. At that time, we were in lockdown and there were no visitors allowed into the hospital. I went straight to the nurse and they just put me straight in the wheelchair and straight into the bed. I was didn't want to have a problem. So.
All right, did anybody tell you what was happening?
Yes, they explained to us all along what they were doing to me. They also kept in touch with my wife and let her know what happened. Everything was okay.
All right, thank you. Fiona?
Yeah, so the process is that if someone walks in, they would present to triage. If stroke symptoms are identified at triage, then it's straight into ED, and we do what we call a stroke call. And that's the appropriate people to come straight to ED, to join the ED nurses and doctors to facilitate the tests that need to be done.
So how soon into Peter's journey did the stroke team actually realise that there was this potential for endovascular clot retrieval, or with the imaging, without getting into too much of the technical details, because we've got Naj here to talk us through that in a little while. So we're looking at a time frame of an hour or an hour and a half or 2 hours?
Normally we would do our process is that we do a quick screener on the patients to see whether they're likely to fit the category that needs to be super urgent. His symptoms were onset less than 24 hours, so we did our triage, our assessment very quickly and straight into scanner. So we expect that the patients would be in the scanner in that scenario within 20 minutes.
All right. Now, Peter, were people talking to you at this stage saying what was happening to you?
Yes, they were explaining giving me days to try and resolve the clot and told me, I had to do I had a scan and I had to go to Sydney. I was also set up like a good now where this doctor in Sydney was actually asking me questions and looking at me and it was excellent treatment where they had as far as I'm concerned.
All right, so thank you. So Fiona, your decisions are being made, you're getting consultation over to RPAH. Where are we on the time frame now? An hour?
No, we wouldn't be quite at the hour. So as soon as we contacted our telestroke service prior to going to scanning so that they can get background information and work out whether this particular patient is likely to have some contraindications to some of the treatments that we might be providing. Then we're in the scanner waiting for the results. The results come through within 10 minutes to the telestroke neurologist. So we would be back into ED and on the TV until the stroke neurologist getting consent from the patient, if able, or telephone through and put me into the family report in this case. So we're probably still within the hour when we make that decision about what treatments are required.
All right, and your next step, so the decision's made to transport Peter to RPAH or to Sydney, where do you go to get someone? Do you get a horse and dray, or do you know, is there something quicker out of...
We did have a license treatment, so that went ahead regardless. And then our process for getting transport to ECR is to contact retrieval.
All right, so that leads to Lynn Hegney, talking a little bit about ambulance and also touching on what's it like to be in a tin can with wings on it, possibly, flying from Orange to Sydney. What's it like for a patient's point of view?
I haven't been a patient on there. It's very beautiful as a flight nurse, I must say. So Fiona, you would get, my current role is in the clinical coordinator in the aeromedical retrieval service, so we would take that call, and the information we would gather for a triage process is the patient's current disposition, their observations, are they stable, are they maintaining their own airway, and that's to determine the crew mix that's needed for transfer. And then the other is the timing to procedures. So, and that's all for prioritisation. So for a clot retrieval, it's generally a priority 1, which means the fastest asset, they call it, would be going out there. And this is given if they're maintaining their own airway, and that could be the helicopter from Orange, it could be a fixed wing which is staffed with a flight nurse, or it could be a road ambulance, depending on weather and where everything is.
Right. So what can go wrong with that process? Not with Peter at the moment, because we're on track. We know that he's heading to Sydney eventually. Mm-hmm. What can go wrong with your processes regarding your machines or the weather or personnel? Anything, or is it just perfect? It works
no, Orange is a classic for it. It's quite high in altitude, and it's notorious for having very, very cruddy weather and clouds that sit on the ground. So that's probably one of the big things. And then, so I'll do the clinical assessment and what we need, and then I pass it to the logistical team. And I'll say, this is what we need, this is the level of care we need. The logistics are also clinical paramedics, so they have a very good understanding of what's going on, and then they look at, okay, can't get into Orange, what's Bathurst like, and start to look at closest airports, what's around. Can't get to the airport because airports are always built on the flat areas that are low and attract fog, but we may be able to land the helicopter at the hospital. So they will look at the other processes of how we can move and what's the fastest possible way of doing that.
Right, and so how many cases, such as Peter, do you think that you've participated in your career, just for stroke?
Look, it's not infrequent. It's quite common.
Right. Quite
common. So probably medical is our biggest amount of transfers, which would be cardiac and strokes.
Very good. So we've got a really good service out there in rural New South Wales. We're just using Orange Bathurst as an example, but we know that there's a broader spread of services using the ambulance service, the Royal Flying Doctor Service, and Care Flight as well. So I was recently out in Alice Springs and we had the opportunity to actually go and get inside the front end of one of these planes. I wouldn't say that was a delightful experience, quite frankly. I thought it was hot. I was lying on a stretcher. I was looking at a ceiling. I didn't have any drips in, by the way. I was just there to see what it is. So, Peter, what
you were in North Queensland and Alice Springs, but it does.
Of course, it's not New South Wales.
It does definitely get hot in the planes in the summer, and you can't turn the air conditioner on until the propellers are turning. But we do endeavour to make you as comfortable as possible.
Sure.
There is no TV. Yeah. You get me for entertainment.
Well, there you go. What more could you want? First class. All right, thank you. Now, Peter, you're leaving the emergency department at Orange Base. I assume that you're in an ambulance on the way out to the airport, and you're strapped in a trolley You're looking at the ceiling of the ambulance, you've probably got IV lines in. What are your thoughts at this stage? You know, you're leaving home, you're going to something that's completely unknown.
Yes, well, very apprehensive. I knew I was in good hands, so I didn't have any worries that way. I was quite comfortable with what was happening, yes. The only thing, when we pulled up out at the airport to transfer into the whatever I was going to Sydney in, there was this tiger moth taxiing there, and I said to them, well, I'm not going in that, you can take me back to the hospital, but the other plane arrived and there was no worries.
Well, it would have been a bit cooler in the tiger moth, I would imagine.
Yeah.
Particularly coming over a little Hartley. Fiona, you've got a comment at this point about this short transfer out of ED. Was there anything else that needed to be confirmed with referral or transport or talking to the receiving hospital?
Yeah, so our process is that once we decide that the patient meets the criteria for clot retrieval, our telestroke doctor makes contact with Royal Prince Alfred Hospital, because that's our referral hospital, and we alert that we need to have acceptance from that hospital before we can ring retrieval and start that process. So that usually is just a phone call. And because it's specialist to specialist, it's usually quite quick. They know what they're talking about. They trust each other. If they need to refer to the imaging, they do that fairly quickly. So whilst the process and the decision making is quick, the logistics do take some time. We would have had to do a rapid COVID test prior to Peter going, and we need to have results from that before he arrived at Royal Prince Alfred. That's one. He's also prepared a little bit by the nursing staff before he goes. So that's all happening in the wings.
Very good. So Peter arrives in Mascot, I assume? Lynn? No?
Yep, we fly into Mascot, right opposite Krispy Kremes.
Oh. Well, this is a stroke conference. I'm not sure we can mention Krispy Kremes, but we will take sponsorship for the Stroke Recovery Association if you get that as well. Right, so off to Mascot, there's an ambulance and crew waiting for transfer to RPAH. Is that how it works?
That's how it works. If once you book transfer, you book it from the hospital to hospital, and then our logistics people book you the road ambulance from Orange to the airport, and then from Mascot into RPA.
Very good. And is there a handover in the department? I'm just going to put that one to Kylie first. So how does that work once it gets to the front door?
So they mostly tend to come via chopper from Bathurst and Orange, so we would meet them on the helipad, so up on level 11, and there is a very quick handover, but generally speaking we don't, because I would have spoken to someone at the other end, so we've got most of the clinical details by the time they get to us, and we've got in between level 11 and level 5 to assess the patient before they then go in to have the procedure. So there's not a lot of time for talking.
So who's on your team at RPAH? Just you, the only person?
Just me, all solo, 24 hours a day. So what happens is when we get the phone call from Bathurst, it comes through to our neurologist, and they then have a conversation with the interventional team, and the patient's accepted. And once we know that occurs, I then start coordinating all of the team. So that involves anaesthetics for us. So I need the anaesthetic doctor, the anaesthetic nurse. We need to get the radiology nurses, the radiographer to come in. We need to get someone to book the patient. The neurology team need to be aware, and then we need to try and sort out beds after the fact. And then we also try and talk to the other end, so Bathurst or Orange, because we need to know COVID statuses now in our new world, because if they're coming in query COVID or we can't say that they haven't, they need to come via a completely different pathway and different entrances into the hospital. And then we also try and have a quick chat with families before they arrive, because often it's a very whirlwind visit at RPA and it might only be 24 hours, so we try and get families to stay at home so they don't have to drive down to drive straight back again.
Great system. Now, Naj, tell us a little bit about your work. I'm not sure, did you treat Peter?
I don't think so, no. He was before my time. I'm glad he had a good outcome though, that's really good. So like Kylie was saying, we work in a very collaborative team together. We actually use the pager system a lot, which I've got a pager in my pocket. So that alerts us to a stroke arrival to the ECR suite or the radiology department. And normally they give us a time limit as to when we should expect the patient to arrive. It's different for whether the patient's at our hospital or coming from a rural centre. And what that means is all our staff have to be ready to come into hospital if that's after hours, or if it's during hours, 9 to 5, Monday to Friday, we evacuate the room and get ready for the stroke patient to arrive. We already have a pre-packaged pack for the stroke, and that has all the equipment we need. We do all our strokes in a very clean fashion, so it's a sterile drape and equipment, and we also have to select our devices that go up from the groin into the brain to allow us to safely evacuate the clot, and the other necessary equipment, including the pumps and other, special metal type stents or objects that can remove a more adherent clot. We have to be very quick, and so that's why communication is essential for us. We are able to look at the imaging via the internet, a secure sort of service, so as to make sure that the route that we're taking from the groin up into the neck, up into the brain is a safe route, and that we're selecting the right equipment, because some patients' blood vessels are very windy, and that makes it a bit more difficult for us. And we also need to make sure that the stroke hasn't caused a lot of damage, because that affects the long-term recovery of the patient and the risk associated with our procedure, particularly the risk of bleeding. But yeah, I think for us, the most essential bit is the communication between the whole team. And at RPA, I've worked at many hospitals, but it's a very good and clear communication, and everyone's very organised, which is fantastic.
Sure. Now, are you communicating with Peter as well, given he's the patient?
Yes, we definitely should be communicating with Peter. When the patient arrives in the angiography suite, there's usually the anaesthetist, the anaesthetics nurse, myself as one of the neurointerventional team, the radiology nursing staff and the radiographer and neurology. And we normally have a handover where we also have a chat to the patient. We let him know what we're about to do. The procedure can either be with the patient awake or the patient asleep. So before we put the patient to sleep, we let them know that they're having a stroke and that we're about to go up through their groin or their wrist, more rarely, to evacuate the clot from the brain, that we've spoken to the family and that they'll be staying with us either on the neurology acute stroke unit or in the intensive care unit afterwards. So it's very important that we talk to the patient. I think sometimes it can get really busy and hectic and people can forget, but we try our best, yeah.
Yeah, I'm sure that's the case across the board for all 6 ECR centres we have in New South Wales. Peter, back to you. Did you understand at this point what was actually going to happen? Even though it had been clearly explained, you're surrounded by all these faces, they've all got masks on and funny blue hats and green hats. You're in a room where there's lights looking down at you. So, any concerns at this point?
No, I don't think so. It was all happening so quickly. I remember when we drove into, wherever we drove into RPA, the ambulance driver said, I wonder where we go here. And the nurse with him said, oh, look, there's someone down there waiting for us. As soon as I got to the door, I was straight out of the ambulance into the wherever it was, the theatre, and I did be put to sleep, so I don't remember too much after that.
No, that's fine. So I'd imagine it was a sign like you get at the airport, hi, I'm Kylie, welcome.
Yeah.
Most certainly, the balloon streamers, it's all there.
All right, let's move through the procedure. Thank you, Nash, for that in-depth. When we do have some actually up the back, some examples of the tools that are used for this particular procedure. They're not takeaways. You can't have them for your children to play with. They're here for you to have a look at, and then Naz will take them back to work, completely unopened, of course. So, Peter, you finished the procedure. You were asleep. So, do you know where you ended up after that? Can you remember? And it's not a test, by the way.
I was in intensive care. That must have been the Saturday morning, I think. I was taken, and I had another couple of scans done, and then I think Saturday afternoon I was moved into the ward, and you know, they said, "Well, we're trying to get you back to Orange as soon as we possibly can," because at that stage we had no visitors. I had nothing. I was in the clothes I stood up in that afternoon, and it was a bit daunting that when I did find out, you know, when I did wake up, that I wasn't going to see anyone.
Yeah, and I think that's a big part of what the journey of stroke patients who come from not only just for ECR but from any rural centre into a metropolitan hospital. You have that litany of distance, and it can be the same out in rural New South Wales as well. So, Kylie, why did Peter go to ICU?
So routinely patients for us post-clot retrieval go to the stroke unit, but it depends on beds. So if there's no beds, they go to ICU, but if someone's clinically unwell, so if we can't extubate them or they've had a very big stroke and they're at risk of more bleeding, then they might go to intensive care if we need to strongly control blood pressure or something.
Right, so the normal practice would be go straight to the acute stroke unit?
So about 60% of our patients go directly to the stroke unit now.
So is that best practice?
It's RPA's practice.
Oh. Which is best practice, by the way.
So we changed the model of care because I think going to the stroke unit is much better for patients than going to ICU. I think it's a very quick process, and I think ICU's scary enough on top of everything else, so I think the stroke unit's a better place. We've got our allied health team, we've got everyone there who's specialised in stroke care.
All right, can you just run me through Peter's next 12 hours very quickly?
So once they've had the procedure, we sort of keep a close eye on them because the risks of bleeding are largest in that first 24 hours. So the nurses, there's normally one nurse to two patients to look after the patient at that point. So Peter would have had OBS done sort of every half hour, every hour for the first 24 hours. Our fabulous allied health team are all in to see him within about 24 hours. So physio, OT, speech path will have seen. For someone like Peter, social work probably wouldn't have been involved because he would have been sent back to Bathurst and Orange the next day. And then we try and get nursing to reassess him at a later date, and we reassess his outcomes at 24 hours and rescan him.
All right. And have you spoken to the family to say that Peter's out of surgery, out of ICU and in the ward?
So if it's when I'm at work, I tend to give my phone number out to everyone. So Fiona would give my phone number routinely to families, so they've got that person to contact. I tend to call them as soon as they arrive to the hospital and they're in the angio suite, and then we call them after the procedure so they know what's happened, and then they know that they can call me at any point for updates. We've also got Mariam on the ward who always makes sure we call patients, especially the ones who are transferred in, and COVID made it very difficult when no one was allowed into the hospital, so all families got called at least once a day.
Excellent. So Fiona, did you get a call? From?
Not directly straight after. I usually send down all the details the following day to Kylie, the data details that she requires, and usually just do an informal how are they going and get a response then. But that's fine. Yep, that's good.
Good. Now, Peter, we're going to move to the point where the team comes around and sees you and says that you've done really well. And at that point, did they actually explain what had occurred in terms that I, as a layman, would understand?
Yeah, I think so. I'm not really sure who I spoke to down there. It was a bit strange. The hospital was a bit strange because of COVID, and I know there was one gentleman that came around to each patient and explained what was happening, and he was trying to get me back to Orange, and you know, but I think I knew what happened. Yes.
Well, that's okay. I mean, we had a talk just recently about the amount of information that patients get in hospital, and some stays, some's retained and some's forgotten almost immediately at the bedside, and that's what happens. You get overcome by the amount of people who are trying to help, but sometimes it's not conflicting information, it's just confounding information in some ways. So Kylie, at this point, Peter's ready to go. What happens?
So we then get back in touch with ambulance, and ambulance arrange the best way for him to get home, so whatever's safest for him in terms of his clinical condition, but also depending on the distance, how far they have to go to how we do it. So some might be road, but a lot of them then go back via fixed wing airplane. And so we arrange that and send him back to Bathurst for the rest of his stroke workup and all of the rest of the neurology care to happen.
So the pressure on beds in all hospitals in New South Wales has been tremendous since I started my training in 1975. Now, does that impact on the ambulance? Are you ready to go? Kylie rings you up and says, "Hi, I'm Kylie. I need a fixed-wing plane. Let's go." Now, does it happen?
So again, it goes on a priority system, and yeah, definitely. So everybody works to try and clean out the major hospitals however we can. Everything we do is based on a priority system, so somebody going back home is not as important as somebody coming in. Not less important, but it's a less time critical journey. So if somebody else needs to come in for a clot retrieval, the plane's going to go there first rather than waiting for someone to come to Prince from RPA, and that's the reality of it. But yes, we do. We've got New South Wales Air Ambulance has 4 planes that fly out of Sydney and are ready to fly every day. And the shifts start at 6, 7, 8, 12, 2 at 2, 16, a 20 and a 22. So there's 24-hour covered. Usually the people going home are put on the earlier flights. It's booked. You've got a better chance of actually getting out of Sydney. Orange weather precludes some people going home to Orange. And again, it's the same service. So we, in the back of a fixed-wing aircraft, there's a nurse and you've got pretty much ICU capability, so all your monitoring is going to be maintained throughout the process. You would not get a helicopter going home.
Oh, what a shame, Peter, no helicopter. So you actually went home?
No, I came home in the patient transport vehicle, yes. About 4-hour trip.
So was that comfortable, 4 hours in the back of an ambulance?
The worst part was that I was facing backwards, and I don't like driving in vehicles facing out the back. But no, I didn't have anywhere to move. I couldn't move. There was not much room in those things, and it wasn't too bad.
Well, I'm sure the patient transport officers would have been making it as comfortable as possible. So Fiona, Peter's back in Orange base, or did he go straight home?
No, he came back to the hospital. Yep. So whilst he was in RPA, they would have started his stroke care, and we continue that when he arrives at Orange base. So he will be admitted to the coronary care and stroke unit. He will have Allied Health resume his treatments, and we will work towards reducing his risk of further stroke and managing his remaining deficits if he has some.
Peter, how long did you stay in hospital?
I stayed about a week, I think, altogether. I think I went home on the Thursday. I came in initially on the Friday, and then I went to Sydney and came back, and I was here until the Thursday. So that was what? Yeah.
All right.
Once again, I didn't have the toothbrush around me. I didn't have any visitors, so I was pleased to get home. But I did have some rehabilitation after that.
Yeah, COVID's a very different time. So, no, it's just what follow-up happens with Peter from the medical point of view?
There are different options. He can be followed up. If he has a neuroconsult while he's here, then our neurologist would follow him up. Because he was at RPA and went for clot retrieval, he had a neurologist involved then, and often they will do their follow-up. Peter might fill you in a bit more on what happened with his follow-up in particular.
Yeah.
Yes, I had a couple of phone calls from Dr. Winters, a gentleman that did my procedure down there, and quite happy with the way I was going, and you know, he seemed to be caring about what had happened to me, and the follow-up, I've got to have another scan in 12 months. So, yeah.
Very good. Thank you, Peter. Naj, anything else?
So the most important aspect of the follow-up is to prevent a secondary stroke or another stroke. And so it's really important that we look for reasons for someone having had a stroke, and that's different for someone under the age of 50 and over the age of 50. But more often than not, people will describe having cardiac monitoring on the stroke unit with Kylie and the team. That's to look for funny heart rhythms or arrhythmias. They'll have an ultrasound of the heart to look for blood clots. They'll always have imaging, so a CT scan looking at the neck vessels up towards the brain to look for narrowings in the arteries of the neck that can be treated to prevent further stroke. And the follow-up also is important about looking at recovery, whether that be from a mood aspect to improve their goals for rehabilitation, speech therapy, physiotherapy and occupational therapy. Some people can complain of spasms, so treatments for that, whether they be pharmacological or medicine-based or non-medicine-based. And from an ECR perspective, the neurointerventionalist will follow up with the patient at about the 1 month or 3 month mark, and potentially even later than that, if there is a need for ongoing endovascular or neurointerventional treatment options. And the neurologist will follow up looking at blood pressure, cholesterol, and looking at the deficits and how to improve them or how to work with the patient to optimise their quality of life with them and their return to work, etc. It's always a multidisciplinary approach, and I think the stroke service along with the neurointerventional service will follow up the patient to try and improve their quality of life long term and reduce the risk of another stroke.
Thank you. So this is not an uncommon case. We've been blessed to have Peter with us today to actually give us his interpretation of the care that's been provided by many specialists right across the state from Orange into RPA. But I think Fiona mentioned to me that this year already there's been 122 patients who have received ECR through the New South Wales Telestroke program. So it is a growing program. It is a very important program. But I've always built my premise on we can do better. So I'm going to ask the 4 clinicians, not you, Peter, you're off the hook. You can sit back and have a cup of tea at the moment. What can we do better? Naj?
I think from my perspective, it's about stroke education and awareness to the community. To not think that slight feeling changes in the hand or the foot might go away, it's nothing, or, oh, my words aren't coming out quite right, oh, it's okay, I think I'll be all right, I won't go to hospital. Because I think recognising that someone isn't quite right, maybe having a stroke or a mini stroke, and acting on it immediately is what allows us as a medical team to then be able to offer a treatment that hopefully would be more effective. Because as everyone says, time is brain, and it's really important that we act quickly. And I think that means that if we can improve awareness in the community, we can allow that to happen.
Oh. Kylie?
Well, once we've worked on the awareness, I think Michelle and I have had this conversation many times. I think ECR comes to Sydney, it's a very, very quick and high turnover, and I think there's often a bit of gap missing in terms of when they return. There's not necessarily the rehab options, they're not assessed the same way, so I think we probably need to work on that link in terms of going backwards and offering the hyperacute. The hyperacute services are fabulous for telestroke, they're offered everywhere now, but the follow-on from that is not so great, and I think that's the next step we're trying to work on.
Very good. Lynette?
I agree. Recognition and use the ambulance service for what it's there for. Call an ambulance if you're not quite right. I think that's... More helicopters.
Oh, more helicopters was the call up this end of the table. Fiona, thank you very much for helping us support Peter out there and bringing online. So you actually get the last word, as always.
Oh, about what you did. I guess I agree. Stroke unit care is really important. So ECR is part of the deal, but it's what happens after that and the continuation of the care when the patients come back and the secondary prevention. But also, I think probably what I think we don't do the best is following the patients actually back into the community. After rehab or for outpatient rehab, we've got limited options for rehab in lots of places. We've got, for example, in Orange, we've got good inpatient rehab, but outpatient options are quite limited. So using what we've got and exploring ways to bridge that transition from hospital, whether it be acute or rehab, into home and being comfortable at home.
Very good, thank you. All right, ladies and gentlemen, and those on streaming online, please thank the panel and Peter.
Thank you.
I'm going to, we've got a few minutes for questions, so I'm now going to open it up to questions, and that can be online and also within the room. However, I'm going to start. Aren't you surprised about that? I actually have two questions, and my first question is to Fiona. Fiona, we talked about when Peter arrived, and pre-COVID times are different and post-COVID times are possibly different. But what happened to his family sitting out in that car in your car park when he first arrived, and he's gone in and he's okay and they're standing out there? What was the sort of connection between your staff and the family outside?
That's a good question. It would be, I imagine, I wasn't actually there at the time, but I imagine it would have been by phone, contact by phone. And I know that when the telestroke doctors are looking at consent for, they need to consent for treatments, and they need consent to be sending a patient off to another hospital. And often they will bring the family in on that call. And that happens often because we get people from out of town as well, and often their family aren't actually in the hospital when we're trying to. So we're used to patching people in from other places, and unfortunately it sometimes has to be the car. In this instance, might have had to be the car park where they were. Peter, do you know how we were communicating with your family at that point? You probably would.
Not really. I know when I got out of the car, my daughter Gemma said, "Will I wait?" And I said, "Well, I don't think so." But anyway, she did waited outside for about an hour, and she finally rang my wife, and I think someone from here had been in touch with my wife, so she left and went home then.
So that's how we do it.
That's how it worked. And Peter, my next question is to you, and that is, how do you think the process could have worked better for you or your family in the whole journey that you've done from Orange to Sydney and back again? What would you see, if any, that there needs to be any improvement in that process for you?
Well, I couldn't see anything that could have been done any better as far as I was concerned. Everything just happened and happened and happened, and a few of the doctors made comments when I came back that I was lucky because it happened so quickly, that the treatment I got happened so quickly, and it sort of saved any problems.
Okay.
Yeah, so I can't see anything. The only hold-ups was that COVID, having to be COVID tested everywhere you went, and it took a bit of time up, but other than that, the treatment was great, yeah.
Excellent. I'm really pleased to hear that. And you have been able to resume your life post-stroke and living healthily in the community?
To a degree, yes. I'm still having a lot of trouble with my swallowing and talking, but that's the only thing. I don't have... as I say, I used to do a bit of exercise, but I haven't even got the inclination to go and have a walk now because, you know, I don't know why, but I just don't feel like it. I'm very nervous driving. I'm a bit worried about driving, but other than that, you know, I'm getting on okay.
Okay, Thanks very much, Peter. Really appreciate it. I'm now going to open it up to the floor here and also online. Do we have any questions online to begin with? I'll just go over there. And if anybody on the floor got a question as well?
So one of the questions online is for Lynette. Do you work across state lines, or do you only transfer patients within New South Wales to New South Wales hospitals? And then if it is an interstate transfer, how does that differ from a state transfer?
So generally with fixed wing for clot retrieval, because it's so time critical to fly out of Sydney is a long time. New South Wales also has the use of a plane at Dubbo. The Royal Flying Doctors plane is contracted to New South Wales Health, and also at Broken Hill. So yes, we do go out of state. We go, if you live in a border town, you'll generally cross the border. So northern New South Wales will go up to Queensland, whether it be Gold Coast or the southern border towns will go down to Melbourne for their treatment, and Broken Hill will generally go down to Adelaide. We are so lucky to live in the country that we live in, and if somebody needs emergency care, it doesn't matter which state your address is in, or if you need it, you go to the quickest hospital, and the doctors are so good, and the whole healthcare teams are so good with their time response. We are just so lucky for where we live.
Can I just get somebody to address the whole issue of the ACT, because there's Goulburn and there's the South Coast as well?
Yep, so ACT is the same as any of the other borders. They cover there's a geographical ring around Canberra, and Canberra Health Service will generally take in their patients if at all possible. So the South Coast towns, they'll do out to Wagga, Goulburn, the Southern Highlands, Tumut, Snowy Mountains area. So if you get sick in any of those areas, you will generally go into Canberra, and the retrieval service will go out of Canberra. Canberra Hospital will accept you and treat you as if they would one of their own residents.
Thank you. I've just got one here from Ralph.
This is a practical financial one to Lynette. Now, if I was Peter and I was 60, didn't have any ambulance insurance or didn't have any private insurance.
Doesn't matter.
Pardon?
Doesn't matter.
How much would the round trip cost?
Doesn't matter. We're so lucky where we live. If you need emergency care, you can call an ambulance, you can get that emergency care, you go where you need to go, and if you never have the money to pay that, then that's what...
The hospital transfers are paid by the hospital.
Yeah, yeah. And I'm a nurse, by the way, not finance, but it doesn't matter.
So I'm just going to reiterate what you said, Kylie. So what you're saying is that transfer from hospital to hospital, the cost of that is covered by the hospital, the retrieving hospital, or the receiving hospital?
So we normally pay that. So the flight to us is half and half.
Okay, so both hospitals would bear the cost of that. That's actually really good to hear, because that's a really good question, can I say. It's one of the reasons that I think people don't often call an ambulance these days, is because they're fearful of that cost. Any other questions? Sorry, got one here.
I'm just curious as to, you said it's very time sensitive, but I think you said also that if somebody's COVID positive, there are differences, there are some changes. Just wondering how that works with the time sensitivity. Is it just as quick? And I know sometimes people, when they're COVID positive, they're quite hesitant to go to hospital, call an ambulance, do whatever, so yeah.
So if you're COVID positive, basically the main difference for us is we go to a different angio suite because we need different ventilations, and you come through a different entrance to the hospital. So we don't slow anything down. So if we're not sure if someone's COVID or they're not COVID, we bring them in the exact same way. We just come through a different route and we just organise different teams. So initially it did slow things down a little bit when we were all trying to get used to the process, but now it's no difference whatsoever.
Any other questions? Okay, I'll take one here and then one online. Okay. Mark?
Thank you. This clot retrieval that you referred to in Peter's treatment, is that a new technique? And what effect does it have on his deficits?
It's a relatively new technique, but having said that, it's about 10 to 15 years old, was when the first research and evidence came out about how effective it is in the right patient demographic. And an effective clot retrieval procedure can dramatically improve the patient's outcome. It's not uncommon for us to see, once we've removed the blood clot, for the patient's weakness, speech disturbance to completely resolve. But that's not every patient. It depends on their whole context, the time, how much damage the brain has suffered already, and what treatments they've received, whether they did get the clot-busting medicine before their endovascular clot retrieval or whether it was just the endovascular clot retrieval. Because it's still a relatively new procedure, we're still learning along the way, and we're on the frontiers of neuroscience and discovery, and I think in the future we'll be able to offer the procedure a lot more than we currently can because our equipment is getting better, and we're probably going to be able to get deeper into the brain vessels to remove some more clots. But at the moment, we can offer the procedure to the right patient and with a relatively proximal or a bigger blood vessel clot.
It's been offered in New South Wales routinely since 2017. So the evidence sort of came out in 2015, 2016, and the services have been running since 2017, 24 hours a day.
So another question from online. Does treatment differ based on what time of day you present to the hospital, such as the time it takes to get you transferred, particularly in rural locations?
I think if you present to a hospital and an acute stroke code goes out, it's treated as a medical emergency and you're attended to immediately, including being transferred to the radiology department for the scans. So time of day to present doesn't affect your long-term treatment or outcomes. In a rural environment, in terms of getting access to clot retrieval, including the transport time, that may be affected, but again, it's across the nation and across the state. There's an acute stroke code that goes out on a pager. All the necessary teams arrive, particularly the neurology team and the stroke service, and they assess you clinically. So it's a very rapid assessment that can be done in under 2 minutes to check what side is affected, whether it's the front of the brain or the back of the brain. They have to ask you when you were last well or ask your family members, and they also need to determine your level of functioning, because that's very important to the treatment options we can offer, particularly in terms of the risks they can pose to the patient. But time of day does not affect your the treatment event like outcome, no.
And I might just finish off with a question that basically ties it all together, because we've talked about Orange today and the transfer from Orange and to RPA. How is it handled? And this is to you, Kylie. How is it handled statewide? So what is the process if I was to have a stroke, say, I'm going Moree, would you still come to you, or is there receiving hospitals?
So in terms of ECR, there's 6 hospitals across New South Wales that offer ECR. So John Hunter, and then there's the other 5 are in Metro Sydney. Every hospital has a referral hospital that they routinely send to. But as a service statewide, we all sort of communicate with each other. So if there's weather issues, so if someone was going to Moree, they would generally go to John Hunter. If John Hunter's got terrible weather, we would happily accept that patient. So no matter where you are, you're going to get offered that treatment telestroke is in 23 sites, and they know we've all got hot numbers to call, so they can call one of us and you'll get guaranteed treatment no matter where you come from.
Okay. I was going to call on you, Mark, to wrap up the discussion, but that's okay. I'll now just use the time to say thank you very much. It was a very enlightening discussion, and I really appreciate the fact that that both Peter and Fiona have joined us remotely to talk about their processes and how it was for Peter in Orange. And I'd particularly like to thank the panel, Lynette, Kylie and Naj, for their expert opinion on how the process works and to give us some understanding of how it works all the way along the line. And I'd particularly like to thank Mark Longworth for facilitating an excellent discussion and bringing his wealth of knowledge about stroke and how stroke has improved over the last 20 odd years, 25 if we're really being specific, in New South Wales, because a lot of that development of stroke services has really come about because of the great work of ACI, Agency for Clinical Innovation, and as a pillar of New South Wales Health, and Mark was the lead on the stroke network for many, many of those years. So please join me in thanking the panel, and in particular Mark.